also called baseball finger or drop finger. Again, like the PIP joint fracture dislocation, it's a ball which is hitting the tip of the finger, which is fully extended, and this gives rise to snapping of the extensor tendon with or without the bone. It highlights how a single millimeter can make a world of a difference. A 1 millimeter terminal tendon lengthening, that is healing in stretch position, can give rise to almost 25-degree DIP joint extensor lag, and therefore you have to correct this to almost a perfect level, otherwise you can have a drooping finger. It can be bony or non-bony, but again the very important thing is you need a true lateral view, and that too a magnified. So what do you see on the X-ray? On the first thing you see whether there is a fracture or no fracture. If it is no fracture and it is still drooping, that's a non-bony injury, it's a tendinous rupture. Next thing you see whether the distal fragment is displaced, out of alignment or not alignment, whether two fragments are in place or they are not in place, and it is subluxated. It can be acute and chronic. The debate about when is acute or chronic is subjective. Again, as at midnight nothing happens that you can say today it was acute, tomorrow it is subacute. The classification has been, if it is arbitrary, the word is arbitrary, within 4 weeks is acute, 4 weeks and 1 day it becomes chronic. What do you want? We want the DIP joint extension should be restored, and you don't want the secondary PIP joint hyperextension to occur. So do they need treatment? Yes, of course they need treatment, and they cannot be ignored. They can be treated conservatively, they can be treated surgically. Patient compliance, the issue with conservative treatment is you have to immobilize them for a prolonged period, and the patient often are not able to use the splints. So when do you operate them? It is open, any open injury requires internal fixation, so this requires surgery. Closed injury with prolonged is anesthetic. Caretaker of the family, if there is an elderly person who is being looked after by a person who sustained a mallet, he said, I have an elderly person in the house, I can't have the splint on, so do something so that I am free and I can look after the elderly person. Or patient has a splint and splint is not working, it is falling apart for whatever reason, he requires surgery. Review of literature, both are good. You have to individualize and ask the patient what you can tolerate. There are patients who just don't have to do anything, they have to sit and just play around and they are fine with non-surgical method. It is difficult to say what is good or what is bad because there is no consensus on whom to operate and whom not to operate. And that was as late as Journal of Hand Surgery American 2017. So important thing is patient has to be a part of the decision making, what to operate, what not to operate, except which are already fixed. Open injuries, they do require surgery, subluxation do require surgery. So what is the treatment? Now the problem is the splint has to be continuously on for 6 to 8 weeks if it is non-bony. Fractures may be fine for 4 weeks. So continuous immobilization for 6 to 8 weeks and thereafter for another 1 month at night. Do not hyperextend. If you hyperextend, that piece of bone is going to pop out, and therefore do not hyperextend. There are various splints which are available in the market and you can use whatever you are comfortable with. The patient had the splint and see the sore that has come. So the moment patient says pain, identify anywhere patient has pain, identify why pain, and usually you will find that the splint is tight or it is a poor immobilization. Like we have been talking about immobilization, it is a wrist which is going into flexion which is giving rise to pain. Therefore every time patient says pain, just analyze why pain. Beyond a day, pain is unjustified, and therefore like this patient had a splint sore which was painful. If it is non-bony, it is tendinous, slight hyperextension is required so that you can approximate the extensor tendon soft tissue together. If it is bony, keep it extended. Patients cannot tolerate splints, and these are the patients who have a brain problem like Alzheimer's, thinking problem, and therefore these are not good candidates for trying to splint. You can apply splint but talk to the relatives and make them a part of the decision making whether to operate or to treat them conservatively. And what you do here is you take a K-wire and pass it outside the joint through the extensor tendon, and as you pass this wire you come almost to the dorsal 1/3 of the middle phalanx and take this wire from proximal to distal, and now as you do this will push the fragment volar word. And now put this wire inside and I engage the bone and put another wire, and this way you can reduce this fragment without touching this fragment. And this is called as a Ishiguro technique, and this is a very good technique in fresh fractures. So discuss the options with the patient. If you treat them conservatively, there is possibility of residual lag. If you operate, you have a residual stiffness. Both cases of residual problem, but discuss with the patient what they opt for. Given a choice, get for operation, because getting the splint on for 4 to 6 to 8 weeks is often difficult and practically not possible, especially in a hot country like ours, especially in tropical weather, especially in summer. Keeping the splint on for such a long time without removal is not possible. It starts stinking, because of the sweating. The patient, you remove the splint from day 0, you again count, and therefore using a splint becomes often practically not possible. But discuss with the patient and choose the option, and as was just mentioned, document whatever is doing. Patient after 2 weeks says, I don't like it, but you already opted for it. So discuss and document on the patient's surgical and non-surgical options were discussed, and patients has opted for non-operative method.